just as mentioned, I'm part of the Florida Perinatal Quality Collaborative, and part of why I'm here today is to basically talk about how the collaborative has been going so far and how the initiative on hemorrhage has been going across the state of Florida, and also to answer any of your questions. So part of the objectives of this session is basically to enable you, the participants, to be able to describe some of the rationale behind what we're doing with the obstetric initiative, and also some of our major objectives, and how to access the tools that you can use in order to be able to participate and to learn some more about the initiative. But then also to state some of the advantages about using quantitative blood loss measurement, and the value of some of the other tools that we use, such as debriefing and simulations and drills. Oh, I did it again. Okay. So I thought one of the most important things was to first say, what is a perinatal quality collaborative? Because I find that's a question that people have across the state. This is a map of the existing state perinatal quality collaboratives. Basically, these collaboratives are networks of perinatal care providers, which can be physicians, midwives, nurses, et cetera, who collaborate with public health professionals. And they have this common goal of trying to improve pregnancy outcomes for women. And they do this by saying that it's not enough for you to say, my hospital is better than the hospital down the street, or your affiliate down the street, but rather it's better to look at your own practices and make sure that what you're doing is based on evidence, and that you are current with the processes that have been determined to improve safety. And the point I wanted to make with this map is that this is not something new. That on this map, if you see these states, the ones that are looking kind of green are the two new states that are developing collaboratives. The ones in purple are collaboratives that are funded by the Centers for Disease Control. And then the rest that are in blue are established collaboratives. So if you look across the country, there are 31 states that either have a collaborative or have one in development. So this is to say that what we're doing here with the obstetric initiative is not new. If you want to argue, you could say we're kind of behind everyone else because so many other states have done this already. And we know that these collaboratives have been successful. They really started off doing a lot of things with the NICU and pediatrics, and because of their initiatives and saying, to different hospitals, well, we need to standardize what we do, they were able to show a decrease in line sepsis. We all know that they've also been able to reduce some of the cesarean rates. Certainly, you've lived through the initiatives to stop late preterm deliveries and inductions. They also have been successful in increasing the number that receive antenatal steroids. It wasn't until recently that these perinatal collaboratives started focusing on maternal health. And all of that came about really when people started realizing that the maternal death rates in this country were actually increasing at a time when they're decreasing worldwide. And that the US really, as a developed country, that we rank behind a lot of other developed countries in terms of maternal mortality rates. So because of this, there was a sudden outcry from a lot of organizations, both within ACOG, maternal fetal medicine, within nursing, pretty globally across the country, a lot of initiatives to try and decrease maternal death and maternal morbidity. And so a lot of the focus has been around hemorrhage and hypertension. So we decided to focus first on hemorrhage. And we stated that our goal would be to decrease both the short-term and long-term morbidity and mortality that's related to hemorrhage among women who give birth in Florida, and then also to provide guidance and support to those who provide care for these women so that they can implement successful evidence-based programs. So this is a figure that states the annual postpartum hemorrhage rates in the United States. And if you look at these, the top line in blue are all of the hemorrhages that are due to, all of the hemorrhages, period. The ones in pink are the ones that are due to uterine atony. And you can see that over time, that these have increased. The hemorrhages that are not due to atony have stayed the same, but mostly uterine atony has been increasing. And the reason why that's good news is that that's something that we can do something about. We can intervene and help decrease those hemorrhages. When you look at the cause of the uterine atony by mode of delivery, what we have is in the top blue line, those are those who had vaginal deliveries after an induction of labor. The pink line are those who had a cesarean after an induction of labor. And so you see, again, this pattern where this is increasing over time. So again, this is something that we can do something about, intervene, and hopefully help decrease those rates back to where they were here or maybe even lower. We care about hemorrhage because it is one of the top 2 causes of maternal mortality, not just in the US, but here in Florida. And when we've looked at the top 4 causes, it's uterine atony, as I stated before, but then also things such as placenta accreta, retained placenta, ectopic pregnancy. So of the top 4 causes, 3 of them will come across your labor floor. When you look at all of the causes of death in the US, pretty consistently the top 3 will be hemorrhage, hypertension, and venous thromboembolism. Here in Florida, hypertension and hemorrhage are very closely aligned, very similar. So it makes sense to us here in Florida to focus on these top 2 causes. Again, this is just another figure showing that most of the hemorrhages will come across your labor floor. They're due to uterine atony, retained placentas, et cetera, that only about 1/3 of them are due to ectopic pregnancy. But it's much more than just maternal mortality. When you're talking about what we call the near misses, so these are individuals that end up in the ICU or that end up sick enough that they almost died, that hemorrhage is a significant portion of it. So when in one study where they looked at more than 9,500 women who were coming from their referral units, they found that although hemorrhage consisted of only affected 8% of the women, when you looked at all of the near misses and near deaths, that hemorrhage was responsible for 18% of them. So again, something it's important for us to focus on. So recognizing this, we set upon to embark upon the Obstetric Hemorrhage Initiative. And so we put out a call for hospitals that were interested in participation. And again, we did not invent this. We were merely following what a lot of other states have already done successfully and implemented successfully. The most, the first people to do it were the California collaboratives, but then thereafter New York was also very successful. North Carolina has also published. And when we put the call out for people who wanted to participate, these were the participants we ended up with. In the beginning, we said we only wanted 30, and we ended up with more than 30 because more than 30 hospital systems across Florida wanted to participate. There are some key aspects to the hemorrhage protocol and the hemorrhage initiative. And it's this recognition that there are certain things that are affecting our ability to manage these women. One of them is to improve our readiness. And we have a number of resources that we use in order to improve our readiness as providers. And it's simple tools such as having a hemorrhage cart, having procedural handbooks, having a partnership with the blood bank, performing drills, making sure that medications that you need are readily available, but also having a plan in place for some special cases, such as it may be something as simple as a previa or a more complex case at one of our institutions where you had a placenta accreta in a Jehovah's Witness. So making sure that you have those plans in place. And for sure, making sure that the unit has education so that they understand these protocols. Other than that, the next step is to making sure that you can improve the recognition. When they look at all of the near misses and the maternal deaths, what was most problematic about them was that about 40 to 50% of them were preventable. And one of the things that was cited as playing a crucial role was our ability to recognize that this was a patient that was sick enough until it was sort of too late. If you look at all of the maternal deaths, 93% of them had abnormal vital signs for 12 hours leading up to the maternal death. The question is, what were we doing about it during that time? Did we recognize it? And so some of the tools within our hemorrhage initiative are based on us being able to more readily recognize that these are people who are sick or are at risk. It's recognizing that there are some early tools to look at. But then once we recognize these people, we also need to have a very efficient response. And so some of the other tools will help improve your response. And these are things such as performing hemorrhage drills. Having a standard hemorrhage protocol with checklists, which people love, and we'll discuss those a little bit later, but also having a massive transfusion protocol. When you look at some of the reasons why we don't respond rapidly to hemorrhages, sometimes it's denial, and I've been guilty of this where you just hope that it will stop. Tincture of time, we like to say, that if we delay long enough, then hopefully the hemorrhaging will stop. It's also lack of practice with these uncommon occurrences. There's also the issue of imperfect estimation or quantification of blood loss. I find it fascinating. We hate quantification of blood loss, and I'm guilty of being one of those people who hated it too. Just like it was mentioned, I used to be in Ohio before I came to Florida. And we did the Obstetric Hemorrhage Initiative back then in 2010, 2011, before I came down to Florida. And I remember being offended that anesthesia was supposed to tell me what my blood loss was. And then I had a case in which there was a placenta accreta, and this was supposed to be a good case from the standpoint that this was someone with a normal BMI who, we were anticipating that we can get through this case okay. And halfway through the case, I turn and I see anesthesia, performing chest compressions. And what happened, which we failed to recognize, was that when we took the baby out and we proceeded to go ahead and do the C-hist, that the uterus suddenly clamped down and she abrupted, and a lot of that blood was from below. And we did not appreciate it up top because we didn't see it because she was bleeding vaginally. And so there was blood pooling down on the floor. And at that time, we had an obstetric hemorrhage protocol, and it was such an efficient machine. Obviously, I was praying, which is a really bad case when you're praying as the surgeon. But what really struck me was how efficiently they were able to get the blood up and how smooth everything ran. And the patient did make it. But for me, that was the moment where I came to appreciate the fact that we did have a protocol in place and that I did see that it was a smoother experience than we had previously had when we had obstetric hemorrhages, and the response was more efficient. And so that was the moment that I started becoming a convert. But the reality is that there are any number of things that will hinder our response. Other than responding, we also need to improve our reporting of OB hemorrhage. And part of that is making sure that we're all speaking the same language. How many times at turnover or sign out you hear that she bled a little, but then you hear that she's anemic? Or that you hear that there was, that she had a postpartum hemorrhage, but then they say, oh, but the EBL was 400, and you're saying, which is it? So we need to make sure that everyone's speaking the same language. And the way that you accomplish that is really making sure that we have set definitions and that we're all following quantifying blood losses and making sure that we're quantifying not just during delivery, but then if she has an event where you think it's a postpartum hemorrhage, well, all of those have to be added together. So for us, these were the key elements to the obstetric hemorrhage protocol. We said that to all of our participants, we would like you to do these 9 things. We'd like you to develop your own protocol, to develop your own massive transfusion protocol, come up with a way to perform antepartum risk assessment, perform active management of the 3rd stage of labor, quantification of blood loss, and a note about the quantification of blood loss. If you look in the literature, there have been 23 studies regarding estimating blood loss. every single one of the 23 studies found that we were inaccurate when we estimated. Now, most of them show that basically we tend to underestimate when there's a lot of hemorrhage. We tend to overestimate when there's only a little bit of blood loss. So either way, we don't do too well. When you quantify blood loss and you use a lot of the techniques that we advocate, you don't get 100%, but what you do is you get it right 93% of the time. So you go from 0% to 93%. I think it's a good thing to do. We also asked everyone to construct an OB hemorrhage cart so that you can quickly respond, to make sure that you had medications and equipment available, to perform hemorrhage drills, and to debrief after any events that you had. So in terms of developing the protocol, basically it's having a written document so that you can respond to hemorrhage. And this has to be a coordinated effort so that everyone has input. So it's not just the obstetricians, it's also the nurses, the anesthesiologists, the blood bank, making sure that everyone comes together and that it makes sense to everyone and that their needs are represented in this protocol. For some of the centers, what they have done is to make sure that there's a complete set of pre-written orders that they can just instantly execute, and that has made for a more efficient use of time, and that they can escalate through the stages. So if you go to a stage 2 hemorrhage, no one has to stop and change the orders that they're already in there. So why do we need protocol? Simply because we know that a response is very complex. We know that we need to communicate, and we know that hemorrhages seem to happen at the worst times, when the middle of the night, on a holiday weekend, when the float nurse is on. So that having a protocol helps to standardize everything, and it takes into account everything else that may be going on around you. Massive transfusion protocol. We know that the resuscitative response makes a big difference. Part of this change and this emphasis in having a massive transfusion protocol was based on lessons learned from the war, and that they realized that the key to decreasing the number of people that you lose from hemorrhage is to increase your ratio of red blood cells and FFP. And so each institution or each participant will have their own hemorrhage protocol, and they vary a little bit. So this is one example of the Stanford where they have 6 red blood cells to 4 FFP, as opposed to the California group where they do 4 to 4. But basically keeping up the ratio, thinking ahead, and staying ahead of your blood losses. The other thing too is that keeping in mind that there are 2 different stages, that you are resuscitating, so then you transfuse looking at the clinical signs, but that you also need to keep in mind DIC treatment, and then the other portion where you're transfusing for lab parameters. So it's not just labs, it's also looking at vitals and being aggressive. So the antepartum risk assessment, very crucial, because some people come into delivery with an anemia that's been there and hasn't been addressed. Or whether it hasn't been addressed as to whether, what's the cause of it, or could we have optimized this patient, beforehand, whether it's something as simple as iron supplementation. Some people need IV iron, et cetera, or for the Jehovah's Witness, making sure that bloodless medicine is involved. So by us asking people to do this, it's saying that you need to pay attention during the antepartum period. You need an order set for admission to L&D that includes some kind of risk scoring for hemorrhage, and using a definition checklist. Now, this is an example of one table, and each site has their own version and what they include in it based on the feedback from their providers. And what they do is basically look for some of these risk factors to classify the patient as either low, medium, or high risk for hemorrhage. And different people or different institutions will do different things based on how they assess the patient. So they may have a different set of orders for someone who's medium risk versus someone who's high risk. But we just ask that some kind of thought process goes into this. Active management of labor, quite simply, is recognizing that there is a decrease in postpartum hemorrhage, decrease in blood loss with an active management of the third stage. This was one of our more controversial points because there were concerns about what does active management really entail. There were questions about how much oxytocin should you use, and each institution had their own differing doses. If you look in the literature, there's nothing that really tells you which dose is best or most effective. And if you look at what ACOG says, ACOG really just states a range. So that was not helpful. And so we left it up to the different institutions to do what was locally most feasible. Because for a lot of people, they get premixed bags, and so they were stuck with the premixed bags. But we just ask that some kind of active management go on, because that has been demonstrated to decrease blood loss. So why quantification of blood loss? Like I stated before, 23 studies that show that when we estimate, we either underestimate or overestimate. And we know that when you're underestimating by as much as 50% of the time. So the most accurate methods, according to the studies, have been to use a quantification method. That by having accurate quantitative blood loss, it prompts everyone to mobilize crucial activities that will help decrease hemorrhage and that will also respond to the hemorrhage. It definitely leads to earlier interventions and improved outcomes. How you quantify, there are different ways. These are some of the ways that we've advocated. Which methods are you guys doing here?
We're not doing it yet,
okay.
But we're going to use the scale.
Okay, you're going to use the scale. So one of the things that we do during our meetings, and we did it with our providers, we went around and we had some standardized chucks and pads with certain amounts of blood loss, and we had our physicians estimate. And the first go round, only 1 out of 32 were able to get them right. After some education and having them use some of these posters, that increased to 80% of them getting it right. So education does make a difference, but from our standpoint, it proves the point that by just visually looking, you're not going to be able to tell exactly how much blood loss there really is. And so we have these tools all around, and we advocate them, and a lot of the participants also have them, so that the providers can have an easier way to quantify their blood loss. So some places will use these under buttocks drapes, which is a very convenient way to just make sure you look at how much is in the drape before you deliver the baby, how much afterwards, okay? And it's important to know because you need to watch for how much amniotic fluid goes in there. Certainly using the tape measurements at the time of cesarean or even at a vaginal delivery also is another method, and having these posters in the OR helps the nurses to quantify it. And then of course measuring. Now it is something, like I said before, is controversial for the providers because they don't want someone else telling them how much blood loss they had. And truly, when you look at when you're quantifying who's telling you, really it's a number of people that you'll have anesthesiologists who may be looking at how much is in the suction cup, and you have the nurses weighing or quantifying the saturation of your laparotomy tapes. So it is a shift in culture for a lot of providers. But like I said, it's one that I had to go through, and eventually over time, you realize that, you get satisfaction when they're wrong, when they tell you there was a hemorrhage, but then the hemoglobin is 12, but that you may find that in fact, though most of the time that they are right, and that the quantitative is more accurate than what you would have estimated it to be. Now, when should you quantify? Different institutions do it differently. We generally advocate quantifying for all deliveries. Some institutions will do it only for cesareans. Some will do it only if they feel there's greater than usual loss. But our goal is that there are no more vague guesstimates and that you continue to quantify the blood loss and that it is cumulative, where it includes whatever losses there were during each stage of labor. Again, it's okay to need help to quantify the blood loss, because after all, we're taking care of a patient and we have anesthesia helping, we have nursing helping. I don't think it's unreasonable to have all of the people taking care of the patient assisting in determining how much blood the patient lost. But again, we just have to get comfortable with that new shift in culture. Hemorrhage cart. Did you guys have a hemorrhage cart? Who participated in developing that hemorrhage cart?
Staff, pretty much, with,
Okay.
With the literature also.
Okay. How often do you check it?
Daily. It's locked.
But
So
someone goes through it every day to?
No, it's locked, so unless we use it, but if it's locked, then
Okay.
everything's in there.
Okay.
But it's checked daily.
So we advocate that, yes, everyone has to participate in figuring out what should go in a hemorrhage cart. Providers, nurses, at our institution we had residents, and actually the residents were the ones who made the biggest changes. But what we find is that you periodically have to make sure that the hemorrhage carts still have what you need, or that or that practice hasn't changed, and that there's something new that you need in the hemorrhage cart. So that someone should be periodically looking at that and saying, does it still meet our needs? Also making sure that people still know where it is, because you have turnover in staff, and so some of the issues that people have come across have been that you thought it was so clear cut, and then but some time has passed and it's not so clear cut. Making sure that all medications that you need and equipment are available. This was another point of controversy for us, that if you go strictly by the literature, they say that Cytotec is not, there's no strong evidence that Cytotec is useful as a primary or adjunct therapy of postpartum hemorrhage. So we got a lot of pushback for that. We're just stating what the literature says, and so even at my own institution, that we still do continue to have Cytotec available, but what we were pushing people to do, which was to not use it as a first line, which was also very important for our trainees for their boards, that even though you may watch some people practicing Cytotec at first line, that's not the first line. Obviously using all of the other tools that are available to you, the Bakri balloons, the B-Lynch sutures, and there are other types of suspension sutures. We were very much advocating that everyone knows how to do them before they actually need them. And it's easy enough to make sort of simulation models of the uterus to practice them, just out of felt. That you can get at any store, and then just stuff it with cotton, and then you can have them practice the sutures before they need them. Hemorrhage drills are another difficult component. So again, some of these things on this list I felt were very easy to achieve, and they were sort of low-hanging fruit. So something like putting together a hemorrhage cart can very easily been done. But something like performing hemorrhage drills is a little bit more difficult. But if you look at all of the important people in the safety industry, they're adamant that drills and simulations are very important. And this is the quote that a lot of quality people like to cite as the problem with medicine, that we are the last high-risk industry that expects people to perform perfectly in complex, uncommon emergencies, but we don't support them with high-quality training and practice throughout their careers. And I find that this is true, that if you want to, you can easily escape throughout your career without a lot of high-quality training for what you're doing, and you can just rely on what you've been taught during residency, and then learn enough to get through your examinations, but not really have that day-to-day quality training. In reality, if you look at learning theory, that the least amount that you're going to learn and retain is from something like this, what I'm doing, the lecture. Okay, that's the least, right? I am the most ineffective, right? that if you look at the way to be more effective, it would be to practice by doing and then to teach others. So simulation falls somewhere in between here. In simulation, you are not only practicing by doing, because you're given a situation or a drill. Simulations and drills are similar. You're given a situation in which you have to bring together everything that you have, but also what often happens during simulations and drills is that sometimes you are educating the other members of the team. So when you hear a wrong answer, or if the other member of the team doesn't know what to do. So it fits in here. So that is why simulation and drills are effective. And when you look at the studies of people who underwent obstetric simulation training, and if you look at their fund of knowledge regarding the event, that a year later they have retained 90% of what they learned during the simulation and drill. If you look 2 years later, that falls to about 60%, but it's higher than the people who never had the simulation or drills. So clearly it makes a difference, and in adult learning theory, it makes a difference. As part of the obstetric hemorrhage, we did ask people to do them, and so we found that this was the baseline data that among the OBs and the midwives, that this was the amount of education and simulation that they were getting. But the interesting thing was that the clinical staff were getting way more education than the OB and the midwives, and they had more simulation. So one of our goals is to close that gap and to have everyone increase. So it's interesting that the least effective method is what we're getting the most of. It's also the easier to do. Some of the challenges with doing the simulations and drills, though, happens to be, the time. Right? Everyone says everyone's busy, or how do you free up all of the members of the team to come do it, or there's inopportune times. And different hospitals have worked ways around it, either having their nurses come in a little bit earlier, or having them stop their clinical activities and have other nurses cover so that they can do the simulations and drills, and then getting their providers to either lead them or actively participate in them. Debriefing after a hemorrhage event, we also ask everyone to do, because some of the best learning happens after you've had a bad event. A bad event really stirs up a lot of emotions, and so for some people, it's a way to decompress. It's certainly a way to discover areas for improvement, because how many times have you had a hemorrhage or some kind of emergency, and that's when you're realizing either no one knew where the cart was, or the cart had something expired, etc. So using that moment immediately after it, when you're most angry and frustrated, to discover those areas for improvement and to provide people with immediate feedback is most beneficial. But the key thing is that it will enhance your retention of information. It'll get everyone to be a little bit more engaged, and it improves the ability of the team to work together. The way that you do these debriefs are very important, that they're going to be most effective if they're really conducted in a way in which it's not punitive and not accusatory, but rather that everyone is supportive, and that you're not assigning blame, but trying to identify why this happened, how you can make it better, and what you should do differently next time. Also, this is another area where people have had a lot of barriers, because after there has been a major event, a lot of resources were used, and so there were a lot of nurses involved, providers involved, and so then everyone has to play catch up. So one institution, the way they worked around that is to set a time for them to debrief afterwards, where they do it either by WebEx or a teleconference, because they don't know where their provider will be. The provider may be post-call or in office, but it's a way for them to still get to do a brief discussion of what happened, how to make things better, but without letting too much time lapse. For a lot of places, we've asked them to develop their own debrief checklists, and we have a lot of examples on our website, but also to designate some trained people to conduct the debriefings. Again, this one is a little bit more challenging given time constraints. We also ask that everyone is encouraged to learn by asking questions, and make sure that the goal is clear, that it's to understand the event and to make it comfortable for everyone involved. So this is just one example of a debriefing form where you go through basically what were, for a hemorrhage, what were the medications used, what were the volume options, who was present, etc. And this is just another example of an OB hemorrhage checklist. Checklists are, again, controversial for some people, that they don't like to use checklists. Different industries use it. We know the aviation industry uses it a lot. There's an increasing call for obstetrics to use it. Certainly it's used in some operating rooms. Is it used in the ORs here? Okay, yeah, and some of the operating rooms, they do have a checklist that is on the wall that they slide to make sure that they've gone through every component, that there is significant data to show that people are more likely to follow all of the best practices if they have a checklist. Like I said before, vital signs are often ignored. And so there's a big push for this recognition of triggers. So in addition to perinatal collaboratives doing this, there is a big group, a maternal safety consortium that involves a lot of different people, ACOG, AWAN, the nurse midwives, SMFM, where they're coming out with these bundles of practice, which are really kind of like these initiatives that say, you know, if you have these conditions, you know, this is how you manage them. This is how you manage hypertension. This is how you manage hemorrhage. But one of them is also recognizing some early triggers. So those vital signs that you shouldn't ignore, that are a sign of trouble, and for you to react to them early. So this is just that concept, saying that, you know, many other areas of the hospital use triggers, and so that obstetrics should be also paying attention to them, and don't necessarily wait for a lab result before you act upon it. This is just a guideline algorithm that we put together for our initiative. California has one. Just about every other state who has an obstetric hemorrhage initiative has one. And it's really just a guideline, something that you can put on the wall to remind you, you know, that if you have a certain amount of blood loss, what stage are you at? What stage of hemorrhage are you at, and what are the things that you should be considering? One of the key things we wanted to emphasize was that this is not just for providers. Sometimes it's for the nursing staff, that, you know, the nursing staff to recognize, well, if you have, you know, greater than a liter blood loss, you know, is my provider at the bedside? Should I be calling my provider? Should I be preparing the OR, et cetera? So this is not just for providers, but for all members of the healthcare team. Now, it is also controversial because people bring up the concept, well, is this cookbook medicine? And that no one wants to practice cookbook medicine. So what is cookbook medicine? It's a term that people use for the practice of medicine where you strictly adhere to guidelines, and people feel that they're not an appropriate substitute for clinical judgment. I will argue with you that it doesn't substitute clinical judgment, because if you go back to this algorithm, that everything, all of these actions, which you can't see here, but you guys should have this algorithm, that all of these actions do take clinical judgment. This algorithm can't tell you what's the cause of the hemorrhage. You still have to figure that out. You have to figure out which suspender stitch you want to use, if even that. What this does is just help give you the bones of consider this, consider that. It's a reminder. It is a tool for everybody, not just providers, but like I said, for the nurses and all the other staff that are responding who may not have as much knowledge, or who may have a different kind of knowledge, and they need to know what's happening in the minds of the other person. So this is a tool for everybody. Does it work? Yes. So this is data from the California Collaborative. And if you look at the years, their baseline period was in 2009. So like I said, this was done a while ago. And they looked at how much blood products were transfused during the baseline period, and it was 165. Okay. Now, when they looked at compared to after their initiative, well, they decreased by a third within the first year of their initiative, and then a little bit more within the second year of their initiative. And so while that rate of decrease dropped in the second year, so easily within the first year, you can drop how much blood products that people are requiring per 1,000 live births by just initiating certain things. And a lot of this is related to recognizing earlier what are the things that you need to do to decrease a hemorrhage. Some of it is also making sure patients get to the right place so that they can get managed for some of these conditions. There's also other evidence that having these safety protocols do decrease variability in what people do for the very same clinical situation, and that they adhere more to evidence-based protocols. They have demonstrated that these guidelines do improve safety for patients, and that safety decreases exposure to litigation. That has been demonstrated by the group in Connecticut, that when they looked at the time period before they had their safety protocol in place versus afterwards, that the number of suits significantly decreased and the payouts decreased. It's also been demonstrated up in Boston too. So these protocols and these initiatives really take everyone being involved, everyone from the department level, the hospital level, nursing. There are tools that, that we use, the documentation forms, because it matters that not only that you do these things, but that you also document them so we can track what's working, what's not working. But then also all of the other tools that take resources, such as doing the drills, having the instruction cards and the hemorrhage kits, et cetera. So the whole system has to be involved for this to work. How successful are we? So far, we just had our mid-project meeting, and we received a lot of great feedback. We found a lot of the providers are embracing the change to the point where we've had more than 20 physicians across the state who've volunteered to come out and give these talks. We had one large hospital system that has decided that beyond their 4 participating hospitals, they're going to implement it system-wide. A lot of people have provided feedback that, they do realize that now quantification blood loss is much different from their estimation, and that they feel that a lot of these protocols and drills have helped improve their response. We actually had a lot of people give vignettes in scenarios where their hemorrhage protocol made a difference in the outcome. So overall, it's been positive. So what do we have to provide assistance? We have our website. We have monthly learning webinars on various topics where we let each hospital notify us if there's a particular topic they need help with. We also try to have another hospital on who may have successfully navigated that one issue so that we can provide more support. We have peer-to-peer connections, where if you need to hear about a specific topic from a peer, we can arrange that. Certainly the Speakers Bureau to go around for presentations. We have an advisory panel to deal with tough clinical questions, and we do get them about once every 2 weeks, where we'll get a really tough question where it really takes all of the experts to come together, review the literature, and come up to a consensus of how to deal with the situation. And we've also been doing site visits to the hospitals to review how their progress on implementation has been, and also to help review some of their data. So if you want more information, that's our website there. We also have our contact people. We have Emily Bronson, who's our improvement analyst, and Annette Phelps, who's the clinical consultant, who helps to really filter a lot of these questions that should you have them and get them to the right people. These are all of our collaborators. that it's not just FPQC alone, that ACOG has been supportive, especially Florida ACOG, the Department of Health, the Florida Hospital Association, AWHON, and the Florida Council of Nurse Midwives, so that this is a collaborative effort of people who believe in this cause and that this will improve perinatal care for all of our women in Florida. Yes, questions?
Quick question. Your feelings about using ibuprofen or Toradol for pain control?
So the question was, how do I feel about using ibuprofen or Toradol for pain control? That's another maternal health question that's very important. I think if it's clinically appropriate, you can use them without increasing hemorrhage. Do you mean postpartum? Yeah. Why, do you have a problem with that here?
I'm the old school, I'd rather not to use it. I don't see any sense.
I think it depends. Now we get into a different question. If you have someone who is morbidly obese and has apnea, then decreasing the narcotics use is beneficial. And so you're really sort of balancing one risk for another.
We seem to have a program of telling pregnant women how much weight not to gain through the pregnancy. It's not a public campaign. What's the ideal way to become pregnant? You know?
Yeah, I do agree that there should be more focus on before you get pregnant, how about you get healthy first? Like I always say, unfortunately, you don't need a license to get pregnant.
And I'm sorry, but when you compare the Iraq war and stuff like that, we're talking with young kids who went to training and they went through a physical. Women become pregnant and you don't know what's inside their heart. You know if they have aortic stenosis. So they should be certified to become pregnant.
So you happen to be speaking to the right person, because I do agree. I do think that preconception care is underutilized. We have a much sicker population now of people getting pregnant than we did 10 years ago, and people aren't getting the care that they need before they get pregnant. And I think that's part of why you see some of the higher rates of maternal mortality. Women are coming into pregnancy heavier, sicker, on more medications, older. You're absolutely correct. I don't disagree. Yeah.
I have two questions. The first one is the debriefing discoverable in a malpractice case?
So it shouldn't be discoverable because it falls under quality and safety, and that's why some institutions, before they participated in this obstetric hemorrhage, they actually spoke to risk management first, that they cleared it by risk management to make sure it wouldn't increase risk for them. And some,
paper trail now once you fill out their form, right?
but it should be de-identified.
Here's my second question. Once you start doing the quantitative blood loss like you recommend, do you do that with every single delivery, even the ones that you're not thinking are hemorrhage deliveries?
At Tampa General, we do. Some institutions will only do it if they think they're concerned, but we advocate trying to do it for all of them. Because how do you know, if you're underestimating to begin with, how do you know you're at the point where there is a hemorrhage, a true hemorrhage?
What do you do different after quantifying? Because if she bled a lot and her crit is 17, we're gonna measure it, and it sounds like a good idea when you see that there's decreased transfusions. It seems that that's more of the active management of the anatomy than the actual measuring of how much blood loss you have. If you have 1 liter or 1.5 liter and her crit is 17 and her coagulations are off, you still have to treat that.
But what we're saying is don't wait for that blood test to come back.
So you're measuring to get out of the denial phase.
Correct. You are measuring.
Because the measurement is going to guide your treatment.
Measuring will get you out of the denial phase sooner.
Okay.
Okay, before.
That makes sense.
And that's how they ended up decreasing how many units of blood were required, because you're treating sooner. And
the measurement itself is not.
Yes, and remember, this is a comprehensive response. You're moving to the OR sooner. You're mobilizing your medication sooner by having a more accurate assessment of your blood loss.
We also have to not get lost in the forest because
Yes.
of the trees. somebody's measuring instead of getting the blood that needs to be transfused.
Correct. But that's when you,
Because our staff, we're all very mission oriented, and they're gonna be measuring the blood instead of getting the Pitocin.
and you know what? We found that in the very beginning of quantitative blood loss that it did take a long time, but after they've been doing it for a while, they get faster at it and are able to focus on other things too. So there is a learning curve. But once you push through that, like most things, then it becomes more efficient.
How do you do it at the C-section? Like at your hospital?
So basically, we have a nurse, you know, the circulating nurse, where she quantifies, and they do have special drapes that they use to
For the laps.
For the laps.
And then the suction canister?
Correct.
And how about underneath the patient? Because that you can't do until the end.
That is true. You can't do it until the end, and that one you're almost left with the attending or whoever, or the surgeon who's doing the case, letting you know if they're concerned. And as that culture becomes a little bit more ingrained, they're better at communicating with the nurses and looking for things like that. But certainly you're going to get the tapes, and then you'll get the canister from someone else who's not doing the case, so that they can keep an eye on it.
Because right now, most of us go by the canister more than the tapes.
Yeah.
But each
But
tape
it-
holds up,
yeah.
I saw now 100
Yeah.
mLs.
Yeah,
So we use 15 or 20. They're all not soaked, but
Yeah.
that's another liter.
Correct.
Just hanging in the.
correct.
Can
Yes.
you repeat the mailing address, please?
I'm sorry,
The
repeat?
mailing address, can you show me?
Oh, sure.
Please, thank you.
And we're always available on Google.
Dr. Lai at the back.
Two separate questions. The first is, do you think there's much controversy left in terms of the ratio of blood replacement, or we pretty much can pick one, or it's kind of, has it become a standard, that's one? And the second thing is, do you find that there are any issues with contraindication, but in the rush of a push cart and so forth, we can't remember the contraindication? Do you find it's useful, for example, to say, asthma, don't use that,
Yeah.
just because it's a
Yeah.
specific problem,
Yes.
you know, analog or something.
Yes. So the issues with blood replacement are pretty standard now. So no more controversy about that. As for remembering the contraindications, some places actually chose on their on that flow diagram, their algorithm, to actually put little asterisks on the side to remind people what the contraindications are, so that it's up to each institution to decide if they think that that's something they need to have there. But I do think it is good to talk it through. I'm someplace where there's a residency training, so we do talk it through all the time to remind the residents. So I do think it's important to know.
Do you do one-to-one with FFP?
We do
and
one-to-one, yes,
Even if you're only giving 2 units, or after 4 units?
after 4.
After 4 units, you
Yes.
start one-to-one?
One-to-one. Mhm. And each institution, I don't know what your protocol is here, each one should have their own protocol just based on what they've agreed with their transfusion lab.
We start after the 4th.
Our protocol is
We have 641 and 441.
Okay,
After
Yeah.
yes.
Just out of curiosity, at your institution, have you guys seen an increase in the average blood loss from your vaginal and your C-section?
Yes.
Since you've been quantifying?
Yes, yes. And you're going to see an increase because in theory, we've been underestimating all along. So we do see it. But what we should be seeing is just what California saw, that even though the amount that you're saying it is goes up, that the number of units you've needed to transfuse over time should go down because you're responding sooner.
To piggyback on that though, do you see that there would be that there would be maybe a move to change the definition of what technical PPH is? Because now we're seeing that every C-section or
Yes.
every delivery is,
Correct.
450.
Yes, so there is a movement, it's called Revitalize, which is a group of people, the same group of people who I mentioned that are coming up with, these early warning triggers. They actually published something in the Green Journal, I want to say last year, where they are meeting across the country, more than 100, different organizations represented, where they're trying to come up with standard definitions for everything. Postpartum hemorrhage is one of them, so that you may see a change in what the definition is. Yes.
was involved 2 days ago in a postpartum major hemorrhage. And I have to say, our nursing staff must have seen your presentation a day before. Because they followed step by step of what you presented.
And how did you
Must have
feel?
seen it a day before.
And how did you feel about that?
I feel, thank God they were there next to me. Thank God.
I swear I didn't pay him. Maybe I should have. but I think you're stating exactly what we're stating, that if you prepare, if you do drills, if you educate people, that response is going to be a lot smoother than it would have been otherwise. Yeah, because it's an uncommon event, so people aren't used to it.
Thank you.
All right, thank you for having me.